Hello everyone, this is Dr. AMAR Suri from Gujarat State Radiology Chapter. I welcome you all to the first case of the case series by Gujarat State Chapter. Under this case series, we are going to present interesting case every week. So let's move on to the case of the week, case 1. A 65-year-old male presented with complaints of abdominal pain, anorexia and weight loss. He had previous attacks of acute pancreatitis in past and history of chronic alcoholism. On axial and coronal T2-weighted images, we could appreciate significant disproportionate dilatation of main pancreatic duct. On coronal images, we can see tortuously dilated main pancreatic duct, its cutoff in body region and minimal dilatation in head region. On 3D MRCP images, we could appreciate the cystic dilatation of main pancreatic duct along with the cystic dilatation of side branches. In pancreatic tail region, there was disruption of main pancreatic duct due to high pressure in main pancreatic duct due to extreme dilatation. This led to collection in peripancreatic space as well as perinephric space. On corresponding CT images, we were able to find out one calculus in proximal body region, but the size of the calculus and dilatation of MPD were significantly disproportional. So, till now we had few clinical and imaging pointers towards diagnosis, and those were history of alcoholism, previous attacks of acute pancreatitis, pancreatic duct stone, massively and disproportionately dilated main pancreatic duct in body and tail region, pancreatic duct disruption in tail region. So the differentials for this case were intraductal papillary mucinous neoplasm, pancreatic duct stricture with disproportionate massive dilatation of MPD and side branch dilatations. Endoscopic ultrasound and fluid aspiration was done in this patient. Endoscopic ultrasound revealed lesion to be multilocular without any sort of vascularity. On fluid aspiration, there was presence of mucin within the fluid. These findings added one more differential to our checklist, and that was mucinous neoplasm. However, mucinous neoplasms have few contradicting features for this case. Mucinous neoplasms do not communicate with main pancreatic duct, and due to lack of this communication, pancreatic duct disruption is not common. It is not associated with pancreatitis usually and common in female gender. Aspirated fluid analysis showed presence of mucin within the fluid, raised carcinoembryonic antigen levels and elevated amylase. Raised carcinoembryonic antigen levels is single most important marker in this case, which rules out isolated pancreatic duct dilatation due to stricture as well as mucinous neoplasms. So, under the impression of intraductal papillary mucinous neoplasm, the surgery was done. Entire body and tail of pancreas along with spleen was removed and was sent for histopathology. Histopathology revealed IPMN with adenocarcinoma. So take-home points in this case were dilatation of main pancreatic duct above 1 cm is pointer for main duct intraductal papillary mucinous neoplasm, especially in aged males. Communication with main pancreatic duct narrows down the differential list of cystic tumors of pancreas to IPMN or pseudocyst, so it is very important finding. Mucinous neoplasms usually are not associated with pancreatitis, IPMNs are commonly associated. Pancreatic duct disruption is common where the high MPD pressure pathology is there, which is there in case of IPMN, but it is not common with mucinous neoplasm. Mucin with elevated CEA in cyst fluid, it is highly indicative of IPMN with malignant variety. And involvement of tail is critical in malignant IPMNs as it warrants splenectomy as we saw in our case. I like to conclude with this one. Thank you everyone. We will see you with the interesting case next week.